Thank you to BSS team to give me opportunity to present this paper in BSSCON, and thank you to my co-guide. Adjacent segment degeneration always start with the lumbar fusion. It follows cricoid and villi degenerative cascades. Radiological incidences always precede with the clinical presentation. So can we classify the adjacent segment degeneration based on the radiological severity changes of degeneration? So purpose of this study to establish a new severity score based on the radiological changes, evaluates its clinical reliability and proposed line of treatment depending upon a severity score and clinical disability. It's a retrospective observation study. The patient operated between 2007 to 2014 are included in this study. All lumbar fusion, open MIS with minimum 5-year follow-up are included in this study. So this is our follow-up protocol in our center. All patients underwent post-op MRI at more than 5-year follow-up. 2 independent radiologists were included in this study, and they studied a severity of disc degeneration, facet arthropathy, and lumbar canal stenosis on final follow-up MRI and X-ray of the patients. So disc degeneration are graded from 1 to 4. That includes normal disc with maintained height, black disc with disc height reduction less than 15%, black disc with disc height reduction more than 50%, instability, or the disc failure that extrusion or the pseudo disc. So this is how the scoring was done from 0 to 3. The facet arthropathy was graded from normal facet, early arthritis, advanced arthritis with lateral recess stenosis, and the facet effusion. And this is how the scoring was done from 0 to 3. The lumbar canal stenosis was graded using Lee et al. Classification, and that graded from no stenosis to severe stenosis group. The disability was graded using a modified ODI score. The patient was grouped into 2 groups. The first group, in group A, the patient who has maintained daily living activity till final follow-up and there is no fresh complaint are included into the group A, while the patient they present with the new fresh complaint of repetitive exercism with and without radiculopathy and disturbed daily living activity are keeping group B. So these are the statistical analysis used in the study. So this table shows that there is excellent clinical reliability between the 2 radiologists to score this radiological signs. 686 patients are included in this study. Average age was 59.6. Average follow-up was 7.2 years. So out of 686, 614 patients having a minimal disability, and their charted radiological score ranged between 1 to 3. In group B, 72 patients are included. Out of that 72, 44 patients have a moderate disability, and then majority of the patient, the charted radiological score are range between 3 to 6. And the 28 patient having a severe disability, and their radiological score range between 6 to 9. This diagram shows that as the radiological score will advance, the disability of the patient will progress. So they come to the conclusion that these are the radiological scores. Less than 3 it is called as no significant ASD, 3 to 6 called as moderate ASD, more than 6 called as significant ASD. So this is the case example. Total score 4 with my moderate disability. The patient was treated conservatively at that time. Another example, the total score was 8 with significant disability and advised surgery at that time. Another example, total score 7, significant disability, advised surgery at that time. This example shows the total score 5, mild to moderate disability and treated conservatively at that time. So the patient having a score less than 3 with no disability, no specific treatment will required. But if the patient having a significant disability, then rule out for the other cause for the disability, and this patient may require a lifestyle modification. If the severity score is between 3 to 6 and mild to moderate disability, conservative treatment will helpful, and this patient may also require a lifestyle modification. But if the patient having a significant disability, this patient will require a strict observation. You may still try conservative trial, transforaminal and epidural injection will help, but this patient may require a surgery in the future. So counseling is very important. And the score, if the score is more than 6, and all these patients, majority of these patients having a moderate to severe disability, and the patient will require a surgery. So limitation, it is a single center study. Observation bias is always there. Retrospective studies. Conclusion, we propose a new scoring system based on the severity of radiological score. It is easy to classify, excellent clinical reliability. It will guide line of treatment for adjacent segment degeneration. And we have started this scoring system to apply in our degenerative lumbar canal stenosis patient to patient to grade the lumbar canal stenosis in our routine OPD. Thank you.